without further ado, Mark Woodcock, MD, Sarcoma Management in North Carolina, updates for 2023. We have Dr. Woodcock's bio there, and then let's find out our top 5 about Dr. Woodcock. So first, Mark Woodcock, MD, received his medical degree from University of Louisville School of Medicine. In 2019, the Lung Cancer Initiative of North Carolina awarded him a fellowship grant to support a research effort to identify characteristics of lung cancer patients who respond to treatments that unlock the immune system against cancer. He was named the 2019 Lung Cancer Initiative Outstanding Fellow Applicant. He works to apply analytical and machine learning techniques to large data sets for answering genomic questions in oncology and immunology. And finally, number 1, Dr. Woodcock is a hematology and oncology specialist with the Division of Oncology in the UNC School of Medicine. Dr. Woodcock, welcome.
Happy to be here. Thank you.
Thank you. And what's one thing we should know about you outside of your professional bio, which is very impressive?
Related at least to my work commuting activities, I'm one of the few folks I think that bike to the UNC Medical Center. I think there's about a dozen kind of daily commuters, and unless the weather is really pretty awful, I typically am there on my bike now as well.
Good for you. Good for you. Now, are you an e-biker or straight old school bike?
So it depends a little bit on the weather. When it is in the summertime, definitely an e-bike. It is difficult to get to campus otherwise up that hill and maintain a presentable appearance in July without a little electric assistance.
Yep, makes sense. Well, we're really glad to have you here. I mentioned poll everywhere. So our first question, these are always kind of softballs. This one is, what word comes to mind when you hear the word sarcoma? And while folks are thinking about that, I'll flash up our disclosures, which mercifully I don't have to read anymore. There they are. You've seen them. And now we go on and let's, if our audience members will go ahead and share that. We'll go ahead and display those. And this is a word cloud, so if we get repeats, they'll be larger. And if you haven't had a chance to respond yet, please take just another 20 or 30 seconds to share, again, the one word that comes to mind when you hear sarcoma. And again, these are all anonymous. All right. Well, I see a couple that are dominating the center of the screen there, and then several others that I'm not too surprised to see. Dr. Woodcock, what's your reaction to our audience submissions?
Well, I think the audience is on to several key themes in sarcoma. I see both bone and soft tissue were listed there. At one point, soft tissue looks like it's kind of fallen over to the side a little bit, but those are the 2 most common areas that we see sarcomas. And then I mentioned the word young, presumably in reference to the fact that this is one of the cancers that we deal with both in older adults, but also in younger folks as well.
All right. Thank you so much. And I'll go ahead and advance to the next slide. And we're going to make a minor change on the back end, and then we'll go ahead and turn over the controls to you.
All right. Thank you so much. As Tim graciously introduced me, my name is Mark Woodcock. I'm one of our medical oncologists with the Bone and Soft Tissue Oncology program at the University of North Carolina at Chapel Hill. We'll be talking today about updates in sarcoma management. I have no disclosures. And we're going to start off here with a question. I'll go ahead and read the stem here before we get to our answer choices. This is a 68-year-old male who comes with a history of obesity and hypertension, is referred to your clinic after noticing a lump on his back. He is not sure how long it has been there or if it has changed. On exam, you note a soft 2 by 2 centimeter mass, just superior and medial to the left scapula on the patient's back and below the level of the dermis, really without any overlying skin changes. It's non-tender to palpation and is easily mobilized on your exam. We have some choices here. I'll go ahead and read those off. First option would be to reassure the patient with no further follow-up. Next would be clinical observation, just to see, keep an eye on the mass going forward. Next would be to order an FNA biopsy of the mass. And then finally, refer to surgical oncology at a high volume sarcoma center.
All right, Dr. Woodcock, how are they doing?
This one was actually a little bit of a red herring. There is a small number of people who I think got it, but most people, this being a cancer talk, have gone after a biopsy. In this case, I think the best answer probably would actually be clinical observation. This is a lecture about sarcoma. This is through Lineberger, where we, of course, we talk about cancer a fair amount. The mass here we described, and we'll go into some more details about this, has a kind of a relatively reassuring exam and kind of clinical presentation. For this, I would probably just keep an eye on it for some time to make sure there was no rapid growth or other changes in the mass going forward. The description in this case was really meant to evoke kind of the classic findings of a lipoma of the skin, which is of course quite common and usually very, very benign. So just an overview about what we're going to talk about. First is going to be the epidemiology, just about sarcoma as a rare disease and some of the more common subtypes that one might see. Next, we're going to talk a little bit about when you do see a mass or a lump, what are some of the features that might lead one to suspect a sarcoma as part of the diagnosis, and how you would proceed with the initial staging and diagnostic workup at that point. After that, we'll get to really talking about chemotherapy, systemic therapy in the curative setting, with a review of the data for both adjuvant, so after surgery, and neoadjuvant, before surgery sort of approaches, and a brief discussion about how we cover these topics and in these approaches inside the UNC Bone and Soft Tissue Oncology program. And then finally, we're going to turn our attention to therapy for metastatic disease. And if time allows, we'll briefly touch on data for immune therapy as well, since that is a hot topic in multiple cancer types, of course. Because I've chosen really to focus this talk on the more common soft tissue sarcoma subtypes, I did think it was worth mentioning that there are some types of sarcomas that are quite common that we're really not going to cover comprehensively during this talk. With the exception of the gastrointestinal stromal tumors listed at the top here, all of these are tumors that in general should probably be referred to a high volume sarcoma center for diagnostic workup and management going forward. People are pretty unlikely to see these, but they might recognize some of the names. Ewing sarcoma is certainly one that is common in children and young adults, and I think has a fair amount of sort of notoriety in the broader medical community. I also thought it's worth mentioning that there are some ultra rare subtypes of sarcoma. There's not really a formal definition for this, but there are some where certainly there are less than one case per 10 million people. And in those cases, it's probably better, they have separate talks, potentially separate treatment options. Really just depends on the particular subtype. I'm going to use some terminology here throughout the lecture, and I've just thought it would be worth defining that now. When we use the term STS, this refers to a soft tissue sarcoma, so a sarcoma that rises effectively outside of a bone. Classically, these are liposarcomas, so fatty tumors, leiomyosarcomas, which are derived from smooth muscle tissue, and these undifferentiated pleomorphic sarcomas, which can arise in a variety of locations and have a very kind of undifferentiated, non-specific appearance. Gastrointestinal stromal tumors are also, I think, formally under the umbrella of a soft tissue sarcoma. However, their treatment is radically different than other types of sarcoma and don't commonly involve treatments like chemotherapy. So even though they're considered a type of STS, I think it's worth noting that it is managed quite differently. And so when we refer to STS, usually within the context of clinical trials, years ago, these would have included gastrointestinal stromal tumors, but certainly within the last 10 years or so, there's a wide acknowledgement that these are not treated the same way and usually will not be included in those trials going forward. Separately, there's bone sarcomas. When we use the term bone sarcoma, there's a variety of subtypes for this, but again, classically, we most commonly see Ewing sarcoma, which can affect mostly children and young adults, as well as osteosarcoma, which affects, again, children, young adults, and then older folks as well. Again, this lecture is going to be focused mostly on the soft tissue sarcomas, with the three most common subtypes being listed there: the leiomyosarcoma, liposarcoma, and undifferentiated pleomorphic sarcoma. So they're going to estimated to be 13,400 new cases roughly in the United States for this year, per the American Cancer Society. One might think that sounds like actually a fair amount of sarcoma, more than one would expect. I put the sort of relative incidences based that I calculated based on some publicly available data from the American Cancer Society, and looking at this, this makes sarcoma about 40-fold less common than breast cancer or prostate cancer, but obviously those are pretty common cancers. And so again, one might ask, 13,000 cases, that's a fair amount. Difference in sarcoma, though, is that unlike prostate cancer and breast cancer, in those cases, the majority of cases are just from a handful of small subtypes that really make up the majority of their cases. In soft tissue sarcoma, we can see the chart here. This is a pie chart sort of breaking down from, I believe it was about 10 years prior to 2020. Some of these histologies are grouped together. So you can see leiomyosarcoma at 12%. This is actually broken down by a few different grades and some differentiated and undifferentiated subtypes underneath it, according to the formal pathologic diagnosis. The only slice of this pie here, the largest single slice of the pie that represents a single type of sarcoma, is the gastrointestinal stromal tumor slice at 7%. So all of these others, the larger slices represent essentially multiple cancer types, with the most common type being just 7% of overall cases. There was a really excellent 2021 French sarcoma review where they looked at a handful of national reference centers, 18,000 cases more than, that were subjected to central review and were classified as one of over 150 separate subtypes of sarcoma. I have their incidences per million persons per year listed here, and the right-hand column. Again, some of these are clustered together: leiomyosarcoma, malignant lipomatous tumors. So that includes everything from really heavily dedifferentiated liposarcomas to these sort of atypical lipomatous tumors. So there's a lot of different individual diagnoses that are under each of those categories. The gastrointestinal stromal tumors here have some asterisks next to them as the most common single subtype, with 12 cases per million people per year in France. So we're going to talk a little bit about when to suspect a sarcoma, with the knowledge that lumps are common, but sarcomas are rare, and then the workup and diagnosis that goes into that. We're going to start off with this section with a case. This has a very familiar stem. This is a 68-year-old male with a history of obesity and hypertension. He's referred to your clinic after noticing a lump on his back. He is not sure how long it has been there or if it has changed. On exam, you note a 6 by 4 centimeter bulge, not really a well-defined mass, just superior and medial to the left scapula, so in the same area as what we saw last time, without any overlying skin changes. The area is non-tender, but it's quite firm and very immobile on your exam. So how would you like to treat this patient? I think first option is, again, reassure the patient with no further follow-up. Next option would be clinical observation. Just keep an eye on it, have the patient come back, see if there's any changes. Next would be to order a core needle biopsy, so a little bit more invasive than the fine needle aspiration that we had as an option for the first case. And then the final option to refer to a surgical oncology at a high volume sarcoma center. All right, it looks like our answers are stabilizing out, and the audience in this case, I think, gets it correct. I think the answer in this case would be to get a core needle biopsy. There are some other things that are reasonable, but of the answer choices that were given, I think the biopsy is probably the best option. Clinical observation in this case would not be entirely unreasonable if you had a really compliant patient. But this mass, unlike our first question, this mass has some concerning features. Its size, the greatest dimension of 6 centimeters, as well as the deep-seated nature, the fact that it seems fixed to the underlying tissues, raises concerns for something, a more malignant process. There are some benign entities that could explain this presentation. The picture actually that I showed is an intramuscular lipoma. So it's a deep but benign fatty tumor. But if I saw this patient, I would say this definitely needs a biopsy. And I think that either a biopsy or potentially imaging would be the most reasonable options to pursue at this point. So what are some of the things we should look for when we see a mass and we're thinking about, could this be a soft tissue sarcoma, something obviously that's potentially malignant? There's not really good formal guidance for this, but Britain's National Health Service offers some suggestions to their physicians for things they should look for. And I think these criteria overall are pretty reasonable, recognizing though that there's no kind of retrospective or a prospective validation for any of these. But any really large mass, 5 centimeters or about 2 inches, anything that seems like it is increasing over time, this is obviously quite subjective. So something that's been growing over 40 years, maybe a little less concerned about, but something that grows, over the span of 40 days certainly would raise a lot more concern. Sarcomas have a tendency to be deep to the fascia. So when you try to mobilize them on the exam and push them around, they'll have a tendency to be fixed to the underlying structures and clearly not just sort of located within the superficial layers of the skin. And any mass that really has pain associated with it as well is certainly a major red flag. For bone lesions, we have much better and more formal guidance. These are the NCCN criteria here, and they're relatively simple. If you're in clinic and are seeing a patient, you have someone who's under the age of 40 who has some kind of symptoms of pain, just even discomfort, and you get an X-ray of that bone and it is abnormal, then they get an immediate referral to an experienced sarcoma center for not only for the initial sort of workup, but also for diagnosis. So there's no need to biopsy, don't need to get any other imaging, just send the patient on. If the patient's over the age of 40, then the criteria actually are relatively similar. There is an opportunity, though, to consider working up for metastatic disease first, if clinically indicated. So if you have someone with who you suspect has another cancer, then it's worth thinking about pursuing that. However, if you have someone, even if they're over the age of 40 with clearly a primary bone tumor that's painful or symptomatic and has an abnormal film, unless you think they have another cancer, they also warrant an urgent referral. There are some germline syndromes, some inherited syndromes that can drive these, inherited SDH mutations, Li-Fraumeni, Lynch syndrome. We see a lot of those in other cancers, and they also can drive soft tissue sarcomas as well. I think a little bit more specific to soft tissue sarcomas and sarcomas in general, FAP, that familial adenomatous polyposis, are one set of patients that are sort of have a predilection for these intra-abdominal desmoid tumors. And sometimes when we find an intra-abdominal desmoid, sometimes we actually end up making a diagnosis of FAP if the patient's young enough. A lot of those patients, by the time they've gotten to their 20s and 30s, though, usually have been identified. And then finally, neurofibromatosis. Neurofibromatosis type 1 is classically associated with gastrointestinal stromal tumors, but also with malignant peripheral nerve sheath tumors. And these are things that we see commonly in patients that carry those diagnoses. So I mentioned about the urgent referral with the bone tumors. And what's the hurry? This is a tumor like any other, and so we don't want to drag our feet. But are these truly urgent? And I think the answer to this is yes. These are truly urgent. We need really early identification. The primary reason we rush these is because osteosarcomas and these Ewing spectrum cancers it's really sort of an emergency to get them worked up. These are typically, when they're caught early, potentially curable cancers. They exhibit rapid growth, and all of these require multidisciplinary treatment plans. So surgery, sometimes radiation. You'll need an expert pathologist on board to make the diagnosis, and delays in these reduces the rate of cure. All of these treatments also ideally will receive neoadjuvant chemotherapy, and so they need to go to a center that can identify these things rapidly, or at least suspect them rapidly, and make arrangements to begin those treatments quickly. There are also some soft tissue sarcomas where this applies. I put a really tiny font note down there in the bottom, just because that's not they're not quite as urgent, but there are some soft tissue histologies where similar guidance does apply. There's a lot of them, and I don't think that it was worth trying to rattle off all of them in terms of a slide. But rhabdomyosarcoma and round cell sarcomas have similar rapid growth phases that also are need to be kind of urgently worked up. If you need for obtaining tissue for these diagnoses for any kind of extremity, body wall, head or neck sarcoma, really a core needle biopsy is what's preferred by NCCN, and it should be all that you need. We really try to avoid FNAs because a lot of these often require multiple sectionings and pathology for staining, sometimes going for molecular testing, and the core needle biopsies, you will have more tissue that can allow us to do those things and spare the patient having to go through a rebiopsy. NCCN also does recommend that those initial biopsies proceed along any kind of predicted future resection axis. So don't, try not to make an unusual path to get to the tumor with the idea that if you have, especially an extremity sarcoma, that might be potentially resected by a surgeon later. You want the biopsy path to probably go along the most likely, which is typically the most direct route to get to the tumor from the skin. In the case of abdominal and retroperitoneal tumors, you can consider biopsy if you're thinking that that patient might benefit from chemotherapy before surgery, or if you think there's a non-sarcoma histology suspected. So if you think they might have another cancer, but if somebody has a large retroperitoneal mass, imaging is consistent with a sarcoma. In some cases, and those patients should be, of course, worked up in a multidisciplinary fashion, but in some cases, it's reasonable to think about just going straight to surgery without any biopsy and then proceeding afterward based on the results of the surgical pathology. I also think it's worth noting that expert pathologists will frequently change the diagnosis, and NCCN recommends that these cases be evaluated at sort of by an experienced sarcoma pathologist. There was two papers that I had found, one from Memorial Sloan Kettering that had advertised that they changed their diagnosis from outside sarcoma diagnosis about 15% of the time. And that usually just means a change between sarcoma subtypes. And in the United Kingdom, the rate actually was advertised at 35% in one paper that I found, which I thought was really quite high, and more than 1 in 3. As far as imaging, we're just going to briefly touch on this. This is relatively straightforward. If you have an extremity tumor that, again, might be resectable, an MRI for surgical planning you could get deep tissue or trunk lesions. A contrasted CT is really all you need. And the only imaging you need for a metastatic disease evaluation is a non-contrasted CT of the chest. And then you're basically done. Most of these sarcomas will travel through the blood and metastasize to the lungs, occasionally to the liver. But in terms of things that are most likely, I think it's about 60-something% of sarcomas that present with metastatic disease will have pulmonary metastasis. And so again, this is also supported by NCCN as well in terms of a non-contrasted chest CT being the preferred metastatic disease evaluation workup. There are some special considerations. These are things that I don't think everybody needs to have immediately at the top of their head. In some cases, we do think about doing either total spine or total body MRI for round cell liposarcomas that have a tendency to metastasize to sites that are outside of the typical CT chest, abdomen, and pelvis. And then CNS imaging, again, we don't get commonly. There are some subtypes as well as some cardiac tumors that can metastasize through to the CNS, but again, quite rare and would not commonly need an MRI or CNS imaging. Regional lymph node basis, don't need to look at that either, actually. There are an exception of a few, again, relatively rare subtypes, rhabdomyosarcoma, angiosarcoma. There are some others that are listed there. But in terms of an initial workup at a place where you don't have a sarcoma specialist, you don't need, unlike a lot of other cancer types, you don't need to look in the regional lymph node basin with imaging. PET CT, we don't really use. There are some disease types where this is really useful, but again, not ones that we would commonly see out in the community. Molecular testing. So this is really increasingly useful in diagnostic workup. It's really less informative for therapeutics in 2023. We have a few targeted drugs, but really not enough. There's a lot of excellent ongoing work in this area. Commonly, however, we do see essentially diagnostic changes on these molecular testing that can help either refine a diagnosis or in some cases reassign one entirely. We certainly have had cases where we've had a non-sarcoma histology suspected. We get molecular testing and it really changes the diagnosis and the treatments dramatically. We see MDM2 and CDK4 amplifications with fatty tumors. There's APC mutations, which are associated with FAP and desmoid tumors, as I had mentioned before. KIT and PDGFR alpha are classically associated with driving mutations for gastrointestinal stromal tumors. And there's diagnostic gene fusions that we see really commonly. And one might ask, how many gene fusions could there be? And here's what NCCN has to say about that. I did take some time and count all these up. I counted 47 fusions. This is just in the guidelines right now, right? So there's looking in kind of the preclinical literature, there's a larger number of mutations that are out there that are suspected to be involved in other soft tissue sarcomas as well. So now we're going to do a brief review of the literature for adjuvant therapy. So this is treatment with chemotherapy after surgery. And I'm going to show a lot of studies here. There's going to be a fair amount of slides, but I think the important thing here is mostly about the conflicting nature of the findings of these various trials that have been conducted over a long period of time. And how can we extract from these little kernels of information to help us drive our clinical decision-making? Because again, as we'll see, the evidence in some cases can be plainly contradictory. So we're going to start off with a 1994 study. This was with the EORTG, a European soft tissue sarcoma group, or study group, had 468 patients. They allowed really any non-low-grade soft tissue sarcoma, and these were randomized to either observation or this CYVADIC, cyclophosphamide, vincristine, doxorubicin, and dacarbazine, a relatively intensive chemotherapy regimen that we don't use commonly these days. They received either observation or chemotherapy after definitive intent surgery. They found that chemotherapy really reduced the risk of local recurrence in some cases, so at the site where the tumor was resected, but made no difference in overall survival or metastasis-free survival. Again, 470 patients, roughly, 1994. This was followed shortly after, 6 years, actually, in 2000. This was by a Cochrane review done by the Sarcoma Meta-Analysis Collaboration Group. They looked at 14 randomized studies that had done prior to the year 2000, 1,500 patients. They were looking at adjuvant doxorubicin-based chemotherapy against observation. Again, this was, of course, a meta-analysis. A lot of these patients in here had gotten either other forms of adjuvant treatments. Then maybe they got radiation treatments, in those cases, they found that doxorubicin improved the relapse-free survival, so reduced the risk that the cancer is going to come back in the future, but only really in extremity soft tissue sarcoma. That there was a trend toward improved overall survival, but it wasn't significant. We follow just 1 year later now with a patient, another trial out of that's an Italian group in Europe, of course. This is 104 patients, high-grade extremity soft tissue sarcoma, randomized to either epirubicin, which is similar to doxorubicin, epirubicin plus ifosfamide, or observation. And they found really a gigantic improvement in both disease-free and overall survival, so 19% at 4 years. 104 patients again. And they followed this up shortly afterward with, in 2003, so 2 years later, they followed these patients for longer, and lo and behold, the benefits didn't completely evaporate, but they were really barely significant after 90 months of total follow-up. The p-value there was 0.04. When they further went back and assigned patients based on kind of their original intent to treat analysis, the overall survival benefit actually disappeared. There was some trend toward improved survival in patients who had received a high percentage of the intended doses. So if they got 85% or more of the intended amount of chemotherapy, they were more likely to have a longer overall survival. But that was an unplanned subgroup analysis. 7 years after that, we get another meta-analysis now with nearly 2,000 patients. This was looking at doxorubicin, sort of yes versus no, so chemo as the chemotherapy, improved local control, reduces distant recurrence, but really made no effect on overall survival. Again, almost 2,000 patients. They did note that doxorubicin and ifosfamide, which was included as one of the possible options in the trials that they were performing for the meta-analysis, or including in the meta-analysis, they noticed that doxorubicin and ifosfamide offered a marginal but significant improvement in overall survival in this sort of meta-analysis, sort of retrospective setting. Go to 2010. This is now a small group of 59 patients. These were treated with either adjuvant radiation or adjuvant radiation plus doxorubicin, ifosfamide, and dacarbazine, a relatively aggressive chemotherapy regimen. So all of these patients got really aggressive treatment after resected soft tissue sarcomas. And in this case, in those 59 patients, the chemotherapy, even this aggressive regimen, made really no difference in either the chance that the tumor was going to come back or how long the patient lived in overall survival. We finally go to 2010, and we now have a sort of retrospective cohort analysis looking at adjuvant chemotherapy, so chemotherapy again after surgery, as we're talking about. But this time they break it apart by sarcoma grade. They included 1,500 patients with grade 3 soft tissue sarcomas at a handful of treatment centers inside Europe. And they found that there was actually a significant benefit for the inclusion of adjuvant chemotherapy in this setting. Again, this is restricted to patients with grade 3 soft tissue sarcomas, which is something the previous trials that we've looked at in some of the retrospective series had not included. Finally, now we go to 2012. This was another EORTC trial, another European consortium looking at doxorubicin and ifosfamide. So now they're trying combination therapies to try to get more like better results. It's 351 patients. They included grade 2 and 3 sarcomas and really did not show any benefit, again, in relapse or overall survival. There's a trend toward benefit in some cases with extremity tumors and high-grade tumors, but again, unplanned subgroup analysis, and that was not considered a sort of a conclusive result. And finally, in 2014, we have the last trial we're going to talk about. This is now another meta-analysis. This looks back to the 2 EORTC trials that we talked about, the one from 1994 with the cyclophosphamide, vincristine, doxorubicin, and dacarbazine, as well as their 2012 doxorubicin and ifosfamide. And piling those 2 trials together and kind of mining that for who would be the subgroups who really might have seen benefit, in a new trial going forward if they could organize such a thing. They found that relapse-free survival was improved in male patients and patients over the age of 40, and that there was worse overall survival with adjuvant chemotherapy for women and those who were under the age of 40. There was notably a significant improvement in relapse-free survival and overall survival for patients who had an R1 resection or had a microscopic margin present at the time of surgery. But again, sort of the large cohorts with less selected patients, really no major benefits for adjuvant chemotherapy. So obviously, there's no comprehensive answer here, unfortunately, but there do appear to be in these subgroup analyses some benefits that appear to be more likely in high-grade disease when there's regimens are utilized that include the drug ifosfamide, not just doxorubicin, and also patients with extremity tumors. So the question then becomes, well, maybe rather than trying to ask the question prospectively, well, what can we offer maybe for patients that are at high risk of recurrence and see, would that somehow just consider treating the highest risk patients? There are a number of ways to do this. I'm just going to touch briefly on these. Memorial Sloan Kettering has a normogram that they developed quite a number of years ago, I think in 2002, looking at the risk of sarcoma-specific death at 12 years. The criteria are listed down there below. And there's a web-based calculator that can help estimate that. So if someone comes to you with a resected tumor, you can plug in those criteria and it'll get you an estimate of how likely the tumor is to come back, again, based on data from 2002. There's a European system called the SINS system that was developed in 2003. This was created based on an analysis of 500 patients in Sweden who had soft tissue sarcomas. And then was validated in another group of European patients. The criteria listed there, basically tumor size, vascular invasion, tumor necrosis. These are all things that we look for in other cancer types. It's interesting to note, though, this does have specific pathologic criteria. Their definition of this microscopic tumor necrosis is not one that is commonly done on samples. They have very specific criteria for the areas involved and how cells were categorized as necrotic or not. And so your your pathologist would need to be on board with performing the evaluation in the way that they intended for that SINS system to really be applicable. And last, we're going to talk about the circulator calculator. This is from 2016. This was a model made on about 1,400 patients with extremity tumors treated at an Italian center between 1994 and 2013. This had multiple other validation cohorts, all within Europe as well. Some of these patients received radiation therapy after surgery, and some of them, about a quarter, got chemotherapy. And so it does kind of muddy the waters a little bit. You can see the criteria there. It's kind of common stuff: age, diagnosis, size, depth, grade, margin status, and then of course the histologic subtype. This has been updated later to include retroperitoneal and soft tissue sarcomas. And then I think also useful is just last year in 2022, there have been concerns about circulator because it was all developed it was developed and validated on European patients. And so there was a nice study here looking at a retrospective set of about 9,800, so almost 10,000 patients in the US with extremity and trunk sarcomas. And they found really strong concordance between the actual overall survival and the circulator predicted overall survival based on the criteria at the time of diagnosis. And this had great concordance across race, income status, education, and as well as the type of treating institution that was working. So based on this, we have been leaning a little more heavily on circulator in terms as potentially at least the best studied calculator in a large set of US patients. And so I think that's sort of our preference here at UNC. We're going to talk now about neoadjuvant therapy. So this is therapy now before surgery. We're not going to go into quite as much detail as we did with the adjuvant data, because here at least there's a handful of studies I think that really kind of highlight the importance of the factors that would go into when you would consider neoadjuvant chemotherapy. So first, this is a trial from 3 years ago, 2020. This was a really big and highly anticipated trial. What they were looking at was, so this is chemotherapy before surgery, so neoadjuvant treatment, and they used the standard of care, doxorubicin plus ifosfamide, versus a histology-tailored approach. As I mentioned before, there's a number of these sarcoma subtypes, and some of them have really known sensitivities to particular chemotherapy agents. And so they ran a fantastic trial to look with almost 300 patients to look at, can we treat these tumors that we know that are sensitive to particular types of chemotherapy with that and spare them the toxicity that comes with doxorubicin and ifosfamide. In order to be enrolled in this trial, they had to have a high-grade tumor, grade 3, had to be greater than 5 centimeters, and located in either the extremity or trunk wall. So they accepted a lot of different sites for soft tissue sarcoma. They wanted to look at relapse-free as well as overall survival. And you can see here the relatively surprising results. The disease-free survival curve is in the top left. The overall survival curve is in the bottom left. The tailored chemotherapy arm is in blue, and the standard arm with doxorubicin plus ifosfamide is in red. And you can clearly see that in fact, this was not statistically powered to detect inferiority of the histologic subtyped chemotherapy, but clearly it was nowhere near as good as the standard of care that we had been using. Fascinatingly, down in the bottom right-hand corner, I have the adverse events from this, and the histologic tailored chemotherapy was really much better tolerated. And so despite patients in the doxorubicin and ifosfamide arm having really high levels of neutropenia, leukopenia, febrile neutropenia, they still did better in the long term than the patients who received the tailored and less toxic chemotherapy. There were, I think, some issues with this trial, though, that are worth mentioning. First, there was no control arm. These were just these are the two chemotherapy regimens, and there's still a question about, these neoadjuvants. This is an unsettled question, I should say, and so not having a control arm, I think, counts against this study. There could be a question about longer follow-up. I think in this trial they looked at, I believe it was 2 or 3 years, and so the question is, with ifosfamide and doxorubicin, you can have some long-term toxicities from that. Would that have an effect? So that's a valid question. And then there's also, I think, an issue of surgical technique. This was done at 32 separate hospitals in 4 different countries in Europe. And, would there be differences in their surgical approaches or something in the local site that might be able to influence these results? But based on this, as a field, I think sarcomas, folks have largely stuck with doxorubicin and ifosfamide. And there was a pre-planned subgroup analysis after this was published, which I think was useful, that did show that most of the benefits in improvements in overall survival went to patients with poor circulator scores. Now, this is against historic controls, so it's not prospective data, and so you have to take that with a little bit of a grain of salt, but it did show that patients with really kind of the highest risk factors would benefit from these more aggressive chemotherapies. So how do we approach these things at UNC? And we use what I think could be best described as maybe a risk-adapted approach. So, if a patient comes in, they have a tumor in place, and, would we think about, treating them with chemotherapy, either before surgery or after surgery? And it comes down to really, I think, a number of factors that have to be kind of carefully considered and discussed with the patient. The first would be the patient has to be at high risk for recurrence with just surgery alone. Obviously a pretty clear criteria: small tumors, lower grade tumors, tumors with less aggressive metastatic potential. There's no reason to subject those patients to chemotherapy in those cases. The next thing would be, are they candidates for intensive chemotherapy? When a patient comes in and it would be unable to tolerate doxorubicin and ifosfamide, that's not to say they couldn't get adjuvant chemotherapy at all, but as we've seen with our review of the data, the regimens with ifosfamide appear to be more likely to have some statistical significance in terms of improvement in either local control or disease-free survival. And so being able to get the most intensive chemotherapy that we suspect may work the best is certainly one factor that would influence whether or not we would offer treatment. Do they have a chemotherapy-sensitive histology? There are some tumor types that simply don't respond that well to chemotherapy. And so in those cases, it's really difficult to consider whether or not you would offer them chemotherapy. And finally, you have to have an in-depth discussion with the patient about really all of these limitations and the unknowns that we have. And there's a lot of patient preference, I think, that helps guide our decision-making kind of beyond just those first 3 bullet points. There's a lot of patient input that kind of helps us decide, is this something that's compatible with the patient's goals and preferences, knowing that some of these regimens have really high toxicities and can lead to long-term side effects. At UNC, I would say that I think that I said in most cases here, I'd like to actually walk that back a little bit. I think in some select cases, we would favor neoadjuvant over adjuvant, and on the balance, probably favor treating before surgery more than after surgery. But again, a very case-by-case basis. The reason for this is because the regimens are toxic. If a patient has a tumor in place, so they haven't had surgery yet, you can offer them chemotherapy, and you can see if the tumor shrinks to decide if the therapy is working. And in those cases, if it works, you can offer more. If there is intolerance or the therapy isn't working, then of course you don't offer any more therapy. When you're in the adjuvant setting after surgery, you're essentially flying blind to some degree, because we know that a lot of these sarcoma histologies are relatively insensitive to chemotherapy. We don't have good data for each of these individual, especially the non-common histologies. And in those cases, it's really difficult to justify offering adjuvant chemotherapy, especially when their patients are having toxicity or at high risk for toxicity. So now we're going to move into another question as we move into talking about other types of disease, metastatic disease. I'll read the question stem here. This is a 78-year-old male now with coronary artery disease who notices progressive left thigh swelling and pain over the last 4 months. His primary care doctor gets a CT scan that shows a 9x12 mass in the deep thigh involving the neurovascular bundle of the leg, as well as a round 2-centimeter solitary right upper lobe nodule. A core biopsy of the thigh mass demonstrates leiomyosarcoma. He's referred to you for treatment recommendations and states he wants to try something, but not if it's really going to make him sick. He's got some mild thigh discomfort as his only current symptom from his cancer. And on exam, he's a thin, older male with some enlargement of his left thigh, but his gait's normal, his lungs are clear, and his performance status overall is excellent. So the question then, of course, would be, how would we proceed and what would we recommend in this setting? First option would be doxorubicin chemotherapy, which we had mentioned, of course, in the setting of these adjuvant trials. Next would be doxorubicin plus ifosfamide, which we've also talked a fair amount about as well. You have to be admitted to the hospital for that. So we're going to bring him into the hospital to give him doxorubicin and ifosfamide. Next would be, these aren't really good chemotherapy options. He's 78 years old. He's got an excellent performance status, but we're going to make him sick, and we should refer him to hospice. And then finally, liposomal doxorubicin, and the doses and schedule is given there. All right, and those answers have stabilized out, so I'll go ahead and talk about. I think the answer in this case, the audience did great. The answer in this case was liposomal doxorubicin. We haven't talked about the data for Doxil or liposomal doxorubicin yet, but in this case, doxorubicin, he's old enough that I think at 78, doxorubicin would be a little bit of a stretch. It's not something that I think would be beyond the pale, but it certainly would be very difficult, and there's a high chance that he would not tolerate. Doxorubicin and ifosfamide, I would say, the audience got it, absolutely not. Would definitely make him sick. May work against the tumor, but if the patient's got high-grade toxicity and can't be on the treatment anyway, it doesn't matter. Referral to hospice, I would say, yes, I agree. Doxil over hospice in this case, especially given the patient's stated preference that he'd like to try something. So now we're going to move into discussion of metastatic disease in soft tissue sarcoma. So the first line therapy, roughly from 20 years from the 1980s, was either doxorubicin or doxorubicin and ifosfamide. And in this case, we have a 2001 trial that we're going to talk about. This is again in the EORTC, the European Consortium Group, looking at common STS histologies, no prior chemotherapy. They had to have a resist lesion in place that they could follow with imaging, and either metastatic or locally unresectable advanced sarcoma. They randomized these folks to either 50 patients went to Doxil, 45 patients went to doxorubicin, so about 95 patients in total. This was not age selected. They were all randomized. So they had, I think, a 19-year-old in the Doxil arm. And here are the curves from that trial. You can see that the PFS is on the left, overall survival is on the right. Calyx is the European brand name for liposomal doxorubicin. And you can really see here that the curves fall right over the top of each other. These did have really low response rates in this trial in both arms, but 12 and 14% respectively. This is probably because they included gastrointestinal stromal tumors. There's also a possibility that the investigators at the centers that were enrolling for this trial may have only enrolled patients with more indolent disease, because if someone had come in and had a relatively advanced soft tissue sarcoma at this time, they probably would have been considered for doxorubicin as the first line therapy. And there's some concern that perhaps people felt that enrolling them and potentially being randomized to Doxil would be doing those patients a disservice. We're going to fast forward now. So that was in 2001. In 2010, we had a retrospective analysis of 10 completed prospective trials, again from the EORTC, looking at ifosfamide regimens in multiple STS subtypes. Interestingly, here they did find a negative association with overall survival in leiomyosarcoma, so the smooth muscle tumors, with the addition of ifosfamide, and they did not find that association in any other STS histology. There had been some limited series of data at the time that this trial was published, showing some activity for doxorubicin and another drug, dacarbazine, rather than including ifosfamide as well. But those were in small patient series, so this is why this retrospective analysis was done. We then flash forward now another 10 years to 2020, and this is now another retrospective trial, but looking at 3 common chemotherapy regimens. Again, these are in leiomyosarcoma, so that smooth muscle tumor that we just talked about. These are, again, all EORTC institutions. And what they did was they picked roughly 300 patients that had metastatic leiomyosarcoma that had previously received one of 3 treatments, either doxorubicin alone, doxorubicin and ifosfamide, as we had talked about before, or doxorubicin and this other drug, dacarbazine, and put them together in kind of a 2 to 1 to 2 propensity matched score to look at the kind of the retrospective data about how those patients had done. And their survival curves are here. The PFS is on the left. The OS is on the overall survival is on the right. Progression-free survival is on the left. And what this shows is that in their propensity matched scores, there was thought to be a significant benefit to, so for progression-free survival, doxorubicin and ifosfamide, as well as doxorubicin and dacarbazine, both looked better than doxorubicin. And in the overall survival group, doxorubicin and ifosfamide both looked worse than doxorubicin and dacarbazine. And that kind of makes sense because the ifosfamide is really toxic. This data definitely does not have any prospective validation, but really a nice series and compelling data base that builds on some preclinical data that ifosfamide probably doesn't work that well in leiomyosarcoma versus other sarcoma subtypes. Again, talking about trials in metastatic disease, we're going to talk briefly about pazopanib. This is an oral tyrosine kinase inhibitor. This was a trial done in Germany, 118 patients, age 60 or older, and they were randomized to either pazopanib, sort of full dose, or doxorubicin. And in this case, you can see the survival curves, PFS and progression-free survival and overall survival are here on the left and right, respectively. Absolutely no difference. So pazopanib, full dose, 800 milligrams, looks about as good as doxorubicin in this relatively small 118 patients over the age of 60. This was followed along pretty closely with another randomized a non-randomized phase 2 trial looking at pazopanib as frontline therapy, again, in patients with newly diagnosed metastatic soft tissue sarcoma. It was 56 patients, so again, a relatively small trial, but they were ineligible for systemic chemotherapy. So these were people that came in and they said, we don't have any treatments to offer you. And what they did instead was that they gave them a dose-escalated protocol, pazopanib, starting at a dose of, I believe it was 200 milligrams twice a day, so about half the full dose of what we usually do. Let's see here. I don't have the progression-free survival curve for this, but just to say the clinical benefit rate, so the rate of either stable disease or shrinking tumors, was about 39%, which is actually quite good. However, this was mostly stable disease and usually was relatively short-lived, usually about 2 months or maybe a little bit more on average before the patients would progress. Only 20% of the patients on this trial required dose reductions. Again, this is obviously a very frail sort of pre-selected population. So I think that's actually quite good that 4 out of 5 patients were able to tolerate the dose escalation protocol and appeared to have at least some sort of benefit with that. And then last, one of the last trials we're going to talk about in this setting is the ANNOUNCE trial. This was just for anybody who's been following sarcoma closely. This was looking at a drug called olaratumab. It is a PDGFR alpha directed antibody that was thought to have a really great activity in sort of preclinical data. There was a phase 2 that showed really strong improvements in overall survival. And so this went to a placebo-controlled, randomized phase 3 trial, 460 patients looking at the use of this antibody in combination with doxorubicin versus doxorubicin alone. And this was, you can see the charts here. Absolutely no difference. In fact, if anything, the folks that got olaratumab with their doxorubicin appeared to actually perhaps have even progressed faster. I don't really want to overly dissect this trial. There were thought that the nature of this phase 2 design, which allowed crossover from the doxorubicin arm into the doxorubicin olaratumab arm, might have really unnecessarily kept those patients on an ineffective treatment, whereas those who were on the intervention arm getting olaratumab would have quickly moved off to another and potentially more effective sarcoma therapy, and that might be what contributes to the observed differences between the progression-free survival here. But overall, this effectively took olaratumab out of the market for treatment for sarcoma. So as it stands today, first-line therapy in metastatic setting, doxorubicin. You can consider doxorubicin plus ifosfamide in the case of metastatic disease where you really need a response, where a patient has an impending crisis. In the case of leiomyosarcoma, doxorubicin maybe with dacarbazine. There's some indications that might be better. Liposomal doxorubicin is also a great option, as well as pazopanib, which we talked about. Our metastatic approach here at UNC, we're getting a little close on time, so I think we may end up stopping after this, but to go through what's our approach for UNC for metastatic disease. So with most metastatic cancers, we begin, in other disease types, we begin with the discussion of patients' goals, how they're feeling, and what are the realistic outcomes from therapy. In sarcoma, this is really critically important, perhaps a little bit more so than other cancer types. We have a limited number of lines of therapy, several of which have prominent toxicities, and none of them have really high response rates that have been demonstrated in trials. And by high, I mean something on the order of 50% or more. The median overall survival with metastatic high-grade soft tissue sarcomas is on the order of about 12 to maybe 18 months, depending on what trial we look at, which is quite short. And so joint decision-making with the patient about how to sequence the available therapies is absolutely critical, really starting from the very first drug that they get. And I have hope that I've impressed on everyone that even in the first line, there are systemic therapies that are available to really most patients who come in, even patients who I've had other providers tell me, perhaps are too old or too frail to be able to tolerate things, and we can have some options to be able to tailor toward those, each with their own risks and benefits. Next is the quality of life with ongoing and future therapy. This involves really a lot of continuous reassessment of the patient and how they're doing on treatment. It's not only drug toxicities, but just sort of the general fatigue that comes with frequent interactions with the healthcare system, this barrage of kind of clinic, imaging, lab, infusion appointments that we ask patients to go through. Because we have really few proven targeted or immune-based therapies, the reality is for patients with most patients with metastatic soft tissue sarcoma, they're going to be in some phase of being on chemotherapy or moving to the next chemotherapy for the most of the time they're on, most of their life while they're on treatment. And because the metastatic disease we see commonly originates and grows in the lungs, a lot of patients, unfortunately not all, but a lot of patients really have low symptom burdens when they initially present, and there's a window where they can really, where they have this, relatively few symptoms, they have metastatic disease, and we decide on what kind of therapy they want to get. And that's important because the quality of life is good without treatment at that time, but also, they've got metastatic disease. And so, treatment is clearly indicated to try to prolong their life, but we need to think carefully about how we are going to impact the patient's quality of life as we offer those therapies and reassess it as we go forward. Multidisciplinary care is absolutely critical in sarcoma. Not all patients receive or require local therapy in the metastatic setting, but we really frequently rediscuss cases to determine, the best timing and the nature of any kind of local interventions. This is usually in the setting of palliation, where we've been intervening to improve a specific cancer-related symptom. But it's also worth noting that some types of soft tissue sarcomas, most notably, I think, leiomyosarcomas and perhaps myxoid liposarcomas, as well as osteosarcomas, a bone sarcoma that we really didn't talk about too much, can occasionally benefit from really a more aggressive local therapy, even in the metastatic setting. It doesn't necessarily get the patients cured, but it can really meaningfully prolong their life, improve symptoms, and lengthen really time to progression and time off chemotherapy. And again, I think that's really critically important for patients with STSs, because we're attempting to sequence a really small number of proven therapies compared to other cancer types. And so making those therapies last as long as possible is really quite critical. And then finally, not all patients receive or require local therapy in the metastatic setting, but I don't really have any backup data to back up these assertions, but I feel like a lot of patients, sort of reach the end of their treatment journey, usually after we've exhausted a lot of treatments, or they've had enough toxicity from treatment that they're not really a candidate for the things that we've got left. And because of that, it's really important to be constantly reassessing how the patient's feeling, what their goals are. Again, we talked about a lot of patients can present initially with sort of low symptom burdens, and those symptoms burdens are going to increase, unfortunately, as the cancer progresses. And reassessing how that is, how the patient's feeling about it, and what their goals are is always really a critical part of treating patients with soft tissue sarcomas. We are right at about the 50-odd minute mark, I believe, Tim. And so I've got some quick slides on immune therapy. The short answer is it's kind of a question mark at this point. There are some subtypes where it works. The majority of cases, it does not work all that well. And I did want to briefly pull up my acknowledgement slides. The summary. So the workup staging STS can be straightforward. Just be aware of these high-risk subtypes and situations that warrant referral. Adjuvant and neoadjuvant care is clearly a case-by-case basis. There's newer data that offers therapies for more frail patients and patients in the setting of metastatic disease. And we didn't get a chance to talk about it, but immune therapy is not widely utilized outside of specific sarcoma subtypes. I did want to really acknowledge all of my collaborators in the bone and soft tissue oncology program at the University of North Carolina. We've got Jake Stein, my colleague in medical oncology, as well as really an excellent multidisciplinary team in surgical, orthopedic, and radiation oncology, imaging doctors, pathology, and then, of course, our excellent clinic staff with Kevin Chins, Stephanie Shea, who really do a great job of helping us helping the patients really kind of be able to manage this journey and navigate it as we move through the treatment process. We also have an excellent young adult cancer program with Lauren Lux and Catherine Swift and others, and of course, thanks to all the patients who participated in these trials to be able to help make the collection of all this data and drive future treatments and help improve them going forward. Thank you.
Great. Dr. Woodcock, thank you so much. Andrew's going to go ahead and give me back the slide control, and we're going to, we have time for a couple of questions. I see that we have one in already, and you mentioned that you didn't have time to discuss immunotherapy, but there was a question that came in. Is there any expectation that checkpoint inhibitor immunotherapies will be effective in sarcomas as they have been in some other typically chemo-resistant tumors such as melanoma and RCC?
So there is a handful of subtypes that have done well. We didn't get a chance to talk about it, but there is one in particular called alveolar soft part sarcoma. It's quite rare and seen mostly in children and young adults. It's driven by a gene fusion, so it has a very strong driver mutation and does not respond to chemotherapy really at all. What's funny, though, is that this gene fusion, this abnormal protein that it makes, is highly aggravating to the human immune system, and these patients have really benefited from the addition of immune therapy. So that's sort of one small example. Unfortunately, overall, the other types that benefit from immune therapy are usually the more common kind of poorly or dedifferentiated varieties that have kind of a so-so response to chemotherapy. They unfortunately also have kind of a so-so response to immune therapy. It's not to say that it doesn't work, but just that it's not like melanoma or clear cell renal cell carcinoma or lung cancer. We have not seen that same level of success.
Great. Thank you so much. And we'll wait to see if we get any other questions. I've got a quick one, taxonomy question. So I'm guessing there's been there's a lot of history to the evolution of what we have, the 70 subtypes of sarcoma now. Do you see that things have pretty much stabilized, or do you anticipate that there'll be additional reclassification as we move forward?
That's a great question. I mean, I think, of course, there probably will be some low-level shuffling, but at this point, really, with the advent of molecular testing and being able to look at kind of the genetic and gene expression changes, both in the DNA and the RNA expression that happen in these tumors, I think it's become really clear that there's been a huge variety of tumors that we thought were all really similar that have been kind of cracked open by that testing, and that is, and so I'm hoping that. That things will kind of stabilize out in terms of the pathologic diagnosis, because of course that's a big challenge. When we look back at retrospective data, we have to consider, well, what was the standard of diagnostic criteria for sarcoma back in 2010, which unfortunately is quite different than what it is today. Yeah.
Thank you. One last question: should PCPs refer out or pursue manage what appear to be thigh lipomas, a patient with a family history of benign lipomas, when to worry about lipomas?
Right. And so I think that the primary care doctors probably don't need to refer all of those out, certainly. Now, again, we talked about the concerning findings, pain, rapid growth. Those would be more concerning. But again, the benign etiologies for these fatty tumors are probably, 100-fold more common than the malignant varieties. When to worry about lipomas, again, the growth, and I think the patient having any symptoms or pain along with it, and then also too the location of it. If this is a superficial fatty tumor, dermatology can probably just take that off relatively easily in their clinic. If it's something that appears to be a lipoma, it's soft, it's kind of squishy, but maybe it's not quite as mobile and it's more deep-seated. Those are areas that again, more about the clinical history, right? Is it growing? Is it rapidly changing? Is the patient having any symptoms from it? If not, you can consider keeping an eye on it. But if so, then at least at that point, I think a biopsy certainly would be indicated. If there's any question or concern, imaging with MRI is also typically very sensitive for these fatty tumors. So MRI or biopsy, if there's a concern. These are not necessarily ones that need to be referred out. Again, we mentioned the bone sarcomas are typically the ones that we most commonly see as sort of emergent referrals.
Gotcha. Great. Thank you so much. Well, we're going to go ahead and do a quick wrap up. We're a little over time, and that's great because you've had a lot of information to share with us. This has been terrific. I really, really appreciate this. I do want to say thank you to the people in North Carolina for their generous support of the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center. Thanks to Benny Obore, John Powell, Oliver Marth, Andrew Dodge, and Nadja Brown, Patrick Muscarella, and Lauren Lowe for all of their contributions to make this and all of the other things we do possible.